helpful in the context of depression, and reduced copayments, which we know are helpful for cardiovascular disease and cancer. And we saw these phases earlier when we talked about the different types of medication non-adherence, but it's important to think about this again when selecting an appropriate intervention based on the phase of medication adherence that we're trying to target. So this will really dictate the specific types of strategies that we use to improve adherence. So again, that first step is initiation, beginning a new medication. And at this phase, you may need to address a patient's willingness to take the medication. It could involve checking in on readiness to change or helping build self-competency and self-efficacy and ability to take medication. And next we have implementation and persistence. And here we need tailored support to promote long-term adherence. Effective strategies at this phase include things like motivational interviewing, tailored support, and goal setting, among others. And we'll talk more specifically about this, I think, later in the panel. And once we've established which phase or phases we're trying to tackle and the general category of components that we're going to use, we need to consider our delivery modality. So where does technology fit in as a tool? I think Dr. Lee will be discussing this in a few minutes, but we need to think about what's most accessible to our population and what's most feasible from both a patient and health system perspective. For example, can our healthcare system afford to implement the technology, and who will sustain it from both a funding and staffing position in the long term? One of the great things about technology is that it can be scalable, but only if we design it to be so. And perhaps the largest challenge of all that we have is getting adherence tools implemented into clinical practice. So first we have to establish efficacy. In other words, that this intervention works under ideal controlled conditions like a trial. Then we have to prove effectiveness, that it works under real-world settings. And relatively few interventions make it into clinics. Fewer still really stand the test of time. So the third step in implementation is this issue of sustainability, keeping interventions working after an initial period of funding has ended. And then we have spreading the program from one clinic to several clinics or perhaps a healthcare system. And that's really where we can have the largest impact. But we need to be sure that we're choosing appropriate interventions. Not everything is ripe for scale up. And this process of giving evidence into practice takes an average of 17 years. So that's a little overwhelming for me. That's about half of a career. And that's often where this tension between research and clinical practice lies. Research often moves more slowly than our clinical fields would prefer. And despite this sometimes lag with implementing innovations, this is really a very exciting time to focus on adherence improvement. As part of the Stage 3 meaningful use criteria, which I'm sure we're all very familiar with, we now have exciting and interesting opportunities to really focus on this work. We have new policies encouraging the use of health information technology, and we're focused now on really engaging patients in their health care. Because it's a quality metric, this also includes financial and business incentives to really improve adherence. The Medicare 5-star rating plan, as I'm sure you all know, is now including several measures that are directly related to adherence and some downstream effects as well. And so with that general groundwork laid, I believe we'll toss the torch to Dr. Lee. Great.
So good morning. It's a pleasure to be here, and it's nice to be out of the fog and a little bit more sun than what San Francisco has to offer right now. Dr. Zulig, that was a very, very wonderful presentation that provides a great overview of setting the stage for what we know about medication adherence and the current interventions. I'm actually going to go into a little bit more detail about specific measures of adherence, what are their strengths, what are their weaknesses, specific interventions that are known to be proven to work, but still there's a lot of limitations with existing interventions. And then there's a lot of new interest around mobile technology, and there's a lot of promise, but it's relatively a new field, and I'll tell you about the caveats around using mobile technology. I do consult and collaborate with many technology companies to build apps, to build interventions incorporating health technology, but I do not have any financial ties. It's one of my own personal choices. They offer me honorarium, they offer me stock options, but I choose to try to remain pure. Also, our university has fairly strict policies. Interestingly enough, I actually have to pay them to do customizations to kind of build apps. But hopefully we'll develop a fruitful collaboration and try to find something that actually works. So this is going to be a common theme that you're going to see throughout the day, that the problem is huge. So I'm not going to go over the numbers because it's going to be grilled into your head by the end of the day. But one of the main take-home messages from this slide is that adherence rates could potentially differ between disease states. Okay, so this shows you that, you know, if we come up with an intervention for asthma, it might not be the same for someone who has schizophrenia. It might not be the same for someone who has hypertension. So clearly there's different types of patient populations, there's different types of specific disease measures, there's different types of specific medications that might relate to factors where adherence differs between different disease states. Going to the ongoing theme that one size does not fit all. And I'll probably be saying that a lot throughout the talk. You're probably going to see this slide as well, that it's a multifactorial problem, and that you have to really figure out on this map where the patient's actually having a problem. It might not be the patient at all. It might be the healthcare system. It might be the provider. It might be the insurance companies. So I usually tell my students who I work with, you want to act like a private detective to tease out what's going on with your patients to find out where the problem in adherence lies. But not only be a private detective, but be one of the nicest private detectives to engage your patients. This is going to be a little bit complex slide. The goal here is not to overwhelm you with the different advantages and disadvantages, all the different strategies to measure adherence, but to let you know that there are different advantages and disadvantages to each one, and choosing a tool to measure adherence is complicated. Many of these often overestimate adherence. They may underestimate adherence. These first three are actually fairly cheap and simple to use. Providers actually asking patients about their adherence is a good strategy, but it clearly has a lot of limitations about how they ask, literacy, time. There's a lot of competing demands in time for physicians. Patient self-report is the most commonly used medication adherence measure, but again, this can often overestimate adherence because there's limitations in recall bias, memory, and simple time. Pill counts are also very easy to use. There's lots of devices to actually measure pill counts. You can actually have the patient bring in their bottles, but it can also be somewhat time consuming, and just because you count the pills doesn't necessarily mean that they've taken them. They might have lost them, they might have shared them, or they might have moved them to a different administration method, for example, a pill box. Pharmacy records and claims data have actually been very, very helpful, but again, there's some issues in actually getting these records, and just because someone gets a prescription medication filled from one system doesn't mean that you're capturing all the medications that they take. And then often supplements and vitamins, over-the-counter medications are not captured in claims data. Drug level monitoring is also very helpful, but it can be very expensive. It requires lab testing, and it can vary depending on when they took the medication and when the lab is actually drawn. And electronic medication packaging, so these are actually newer technologies that we use to actually serve as both a measure of adherence, but also as an adherence intervention itself. These can actually help patients take their medications, have reminders on the pill bottle themselves, but again, it might be complicated depending on the systems that you use. There's MEMS caps, there's many other types of interventions, and you also have to make sure you capture all the medications a patient might be taking. And then also with the different types of medication adherence scales, they can differ depending on the types of disease that you're measuring adherence in. We actually have a lot of disease-specific types of medication adherence scales. Probably the most popular one is the Medication Adherence Questionnaire, which is also known as the Morrisky Adherence Scale. But there's the BMQ, the Brief Medication Questionnaire, the SEAMS, the Hill-Bone Compliance Scale, the MARS, which is actually pretty good because it actually gets at reasons for non-adherence. But I think one of the big challenges is that you have all of these scales available to you. Which one should I use for which patient population, for which disease? So it can be very, very challenging. And interestingly enough, as people who actually do this research, they'll validate their scale in one population, but it might not be validated in another population. Or someone comes around with a scale that they think we're going to make a better scale than yours, and they'll show that your scale is not so effective, but ours is better. So there's lots of competition, and it's kind of really hard to tease out which scale should we really use. The bottom line, though, is there's no gold standard for measuring adherence with any of these scales. The specific measure varies by the different types of provider, as I mentioned, by different types of patients, patient characteristics, and by whether or not the system might have some limitations itself. And I think a key take-home measure is that, are we trying to measure non-adherence or really get at the reasons for non-adherence? Because measuring and identifying a non-adherence is the first step, but if you're going to implement an effective intervention, you really need to get at the underlying cause of what the reason for non-adherence is. There's lots of effective interventions out there for improving medication adherence. I'm actually going to cite research from an ongoing systematic review that's published in the Cochrane Library. This has actually been published multiple times, probably throughout the last decade. The senior author is Brian Haynes. He's a wonderful clinician who's an expert in medication adherence. But the bottom line is that there's no simple intervention to improve medication adherence. They're all complex. They're often delivered by pharmacists, nurses, and other allied healthcare providers. So it's wonderful to have an interdisciplinary focus and an interdisciplinary group that's here today. They take a lot of time. They require intense education, counseling, monitoring, and motivational interviewing. In fact, motivational interviewing is so important that we've actually incorporated that into our curriculum that we teach the pharmacy students. It's designed to overcome multiple barriers, not just one barrier, and it's really designed to support the individual with tailored, focused interventions. And how are you going to be able to figure this out? Again, you have to play a private detective. Again, you have to engage the patient. Again, you have to communicate well. So when I start to talk about technology, one of the take-home messages about technology is it's just one facet of these interventions that we can offer. I think a lot of folks are thinking that technology can be a solution on its own. No, it's probably going to be used to enhance the other multi-components of the intervention. And then there's frequent interaction with the patients focusing on adherence. So this isn't kind of a one-time, let's educate you, see you later. You're going to have to do ongoing monitoring, ongoing education, ongoing assessments and reinforcement. Many of the limitations of the interventions that we know now is that while we think we have a good understanding of assessing and intervening for adherence, we really don't. It's really, really hard to tease out. We cannot generalize populations, diseases, people. You really have to do an individually tailored intervention. There's lots of differences between diseases and conditions, patient populations, the type of intervention you're actually going to provide, how you actually measure adherence. There's proportion of days covered, there's medication possession ratios. Sometimes people cut it off at 80%, sometimes people cut it off at 90%. So there's lots of different ways that these studies are done, so it kind of creates this, we're really not sure where the target is. We really don't understand what's actually going on. And then clinical outcomes are often missing. So we're measuring adherence, which is good, but does that actually lead to reduced heart attacks, better blood pressure control, fewer strokes? You know, are the clinical outcomes actually being achieved? There's often inconsistent effects between studies. So again, one study might show this intervention is effective, another study might show it's not. Well, gosh, how do we figure that out? And that's where you go back to looking at the quality of the study that's being done. And then the coordination between patient, provider, and system is extremely important. So if you want this intervention to be effective and sustained, you have to have all three parties involved, the patient, the provider, and the system. Because if you're just focusing on the patient, you're only going to get so far. And finally, as we've talked about earlier, the intervention must be maintained for the duration of the therapy. It's not just a one-stop intervention. It's something that's ongoing that requires lots of resources. And we're just going to switch gears briefly about medication tools and technology. There's a ton of things out here, and many of you have seen apps, but I'm kind of broad. This slide is just to show you there's very, very low-tech, like pill boxes, which are maybe a few dollars, to something that's in the center here, which is made by Proteus. They're a company who's building a medication monitoring system where you can actually take a pill that's dissolvable and it sends a signal to know whether or not you've actually taken that pill. So some very high-tech technology. Now, I used to ask if anyone in the audience had an iPhone or a tablet. Now I ask, is there anyone that does not have a cell phone or a tablet? Right. So technology is, adoption of technology is rapidly accelerating, and so there's this big idea that mobile health will be a huge help in the fight against non-adherence. And it's a term that describes the use of mobile communication devices and multimedia technologies for health services, information, and communication. And some common health applications are collecting clinical health data, so recording and sending, providing health information to patients and providers, which is probably the most common. You can actually monitor patients' vital signs, provide direct provision of care through telepharmacy, telemedicine, social support and networking, which is actually turning into be a huge intervention that can be helpful using Facebook and Twitter. And our focus is to improve medication use. The potential benefits is that it could reduce healthcare costs and improve health outcomes. And there was an editorial in JAMA that was published in 2013 that was encouraging the use of mHealth, but also pointing out that it's still a new field that we really have to come up with strong evidence to see if it works. And if you start looking at mobile apps, if you go to the iTunes or Google Play Store, you'll see probably thousands of apps out there. I actually have a study that's under review where we evaluated over 500 mobile apps for medication management and medication adherence. I'd probably say out of those 500, I can tell you that maybe 6 or 7 were actually very helpful.
Can you say which they are?
Yeah, I'll tell you offline. So patient perspectives on mental health. So there's a lot of patient factors involved, but I don't want to go through this slide each one. I just want to let you know that there's actually existing technology solutions for each of these factors, okay? The problem is that they're not packaged in a nice way that makes it easy to help the patient, okay? So for example, right now you probably need 3 different apps to address all of these patient factors. Provider perspectives. So I think the key thing for them is that they really want interoperability. They really want security. For example, it needs to comply with HIPAA regulations and secure PHI. And it needs to help them communicate with patients. Again, there's existing technology that works, but packaging it in a nice way that integrates into the healthcare system to connect patients and providers is very challenging. I probably have to just emphasize that, for example, health information exchange agreements, while we can actually create ways of sharing information, technology is not the barrier. It's whether or not the organization is willing to exchange this information. So the current limitations and concerns with mobile health for medication adherence is, I also have a systematic review that I've looked at all of the mHealth technologies that have been studied and published in the literature. There's very few evaluations, there's very few randomized trials of an mHealth app on medication adherence. Most of them are about usability and implementation, but not really giving you the clinical outcome of whether or not this mobile app will improve medication adherence. There's issues around security of personal health information. There's issues around slow adoption. I think this is more so because there's too many choices. As I mentioned, there's over 500 apps, probably now more than over 1,000 apps for medication adherence, but which one do we choose? There's lack of integration within the healthcare system. There's costs to these devices. Most of these apps are free, or they might be only a few dollars, but someone has to own a device. And Dr. Kaufman's probably going to talk a little bit about disparities, and there's some disparities across the digital divide. There's lack of, you have to adhere to the use of the app itself. So if you're going to have difficulty adhering to a medication, well, you have to adhere to using the app. And as I mentioned, we already are seeing there's a published report on disparities of mHealth use by racial and ethnic groups, by older adults, and by people with lower health literacy. And we're still on the fence about how to regulate these apps. So the FDA plans to regulate existing apps that are associated with a medical device. They'll be under scrutiny. So if you have a device that measures blood pressure on your iPhone, which we do, then that would be an extension of a sphygmomanometer to measure blood pressure. That would be under strict regulations. But these mobile apps that are just collecting personal health information, collecting medication lists, sending reminders, they're not regulating them currently. But we have to wait to see if something terrible happens, a security breach, then maybe they'll come down. And so that might change the landscape of how these mobile apps are used. There are many opportunities. So the key thing is that they have to address the patient factors, they have to address the provider factors, they have to engage both providers and patients. And it's the same thing. So it's an app that we need to improve behavior change. Medication adherence is a behavior. We're trying to improve that. Adherence to a medication, a mobile app is also behavior. So it's an ongoing kind of behavior change model and sustained use. It needs to be simple, customizable to the patient and affordable. And it also has to relate to these 5 different factors that, again, is an ongoing theme. One size is not going to fit all, but there is potential. And I think that really how technology will be helpful is not as a standalone intervention, but as a way to maybe make it easier to engage patients, to communicate between patients and providers, and to provide them more effective reminders. Thank you.
Good morning. So first of all, I'd like to thank the organizers for inviting me and having me. I find that I'm learning as much or probably more than I'm actually going to present, which is always wonderful. I also have good news, and that is that I agree with absolutely everything that has been said so far, which some of my colleagues back home might find surprising, because I'm always looking for where's the problem? Where are we missing things? So in a sense, that's my objective. What I'd like to do is present some data, some information in particular about health disparities in order to provide the context and the magnitude of the problem, but also then to give some of the data on adherence, and some of it is going to overlap with what has already been said. And then finally, I want to suggest an approach that perhaps we don't always think about. So, first of all, the disclosure, and being a federal employee, I have to state that the views in this presentation are entirely my personal views and do not represent National Institutes of Health or any other federal agency, and I have no conflicts of interest. So first of all, here is the good news. Coronary heart disease and stroke over the years, if we take a look at what has happened since 1980, and I know that there's a pointer over here someplace, since 1980, the good news is the tremendous decline in coronary heart disease and in stroke over the years. This is on a US population level. The bad news is that when you take a look at US life expectancy by race, and the black race, of course, is the one that's been studied the most, but you could say the same thing about others, and I'll comment on that in the next slide. You find that there is a tremendous disparity between in life expectancy, and we really have not succeeded in reducing this very significantly over time. This has really been a challenge. And if you take a look, this is a kind of a landmark paper by Chris Murray that he published with a very catchy title, 8 Americas, which profiles the disparities in different subgroups of the population. Now, I heard him speak once, and what he said is that the choices that he made for 8 Americas are totally arbitrary. They were his personal choices. Somebody else doing a similar study could have taken the cuts differently, picked different subgroups of the population and so forth, but he wanted to illustrate that in America we have a wide range of subgroups with different life expectancies and impacts on health. And at the top are Asians, and when you come all the way down here to Black, high-risk, urban males, the discrepancy, the difference in life expectancy, both for females and for males, gets down to the region of some third world countries. And if you take a look at it, even within the same subgroup, here's white, low-income, rural, Northland Americans with a life expectancy of 76 years, and then you get down to Mississippi Valley. There's a difference of 4.4 years in life expectancy. That's a huge difference. And so even subgroups within races have different cultures, different environments in which they live, different health behaviors, and so on and so forth. And that's important, perhaps, in finding the solutions that we seek. Adherence may contribute. I actually wish that I would have found a really good article, but I didn't. And maybe some of you know of one, in which case, please let me know what that is, where adherence has been evaluated as quantitatively as to its contribution to health disparities. What we do know is that adherence is critical to health outcomes. And as we see that the number of medications to which patients are adherent increases from 0 to 3, there's a difference. Here's a 1.2 hazard ratio of major cardiovascular event with total non-adherence. And this drops down to, what is that, about a 0.75. So there's a difference about 45% in event rates depending on adherence to medications. And certainly, as we will take a look later on some additional data, one can infer that this also has a role to play in health disparities. So the problem, which has already been articulated very well by the two speakers before me, is that approximately a third of the patients with a history of myocardial infarction and approximately 1/2 without do not adhere to effective cardiovascular preventive treatments. And that includes hypertension control and serum cholesterol levels, among others. The interesting thing is